Okay, hi, good morning. It's great to be in this great city, Athens, which I love, and be presenting on a topic that I don't know too much about, I have to be honest, schizophrenia. I have done some research in child abuse, and I'm more familiar with that topic. I was really invited to do this study as a case study from the brother of the subject in Melbourne, Australia. The study took place in Melbourne, Australia. It's a single subject case study, a participant observation and exploratory qualitative study. The subject was a second generation Greek Australian male in his middle 40s, living with his brother, which is a couple of years older than the subject, and I would say their social class is middle class. This was the youngest child out of 7 children, and the subject was very fluent in Greek and also in English. He was actually born in Australia. Okay. Yeah, I was looking for my objectives page, and I just now realized that my objectives page was further down the road. I'm sorry about that. Okay, so the objectives for my presentation for today are to briefly describe the sociocultural context of the study and primary subject and caregiver characteristics, to explore the subject's social history and implications for the onset of schizophrenia, to identify client strengths that are conducive to treatment, to explain the intervention focus and particular strategies employed to enhance problematic subject and caregiver behaviors. And the last objective for the day is to examine the results of the intervention in the context of previous research and derive primary conclusions. So the subject, I already described the subject. I'm going to go briefly now through his social history. Beginning at age 6, he had signs of obsessive kleptomania, and the informant was the brother, the caretaker, the main caretaker. Initially, he was yelled at and threatened with police arrest by police, by shop managers and staff. Repeated incidents resulted in being pushed and ear-pulled by store manager and phone calls at home. At home, he was being beaten severely by older brothers and the father. Kleptomania was seen as bringing shame to the family, and they were also concerned about the potential legal troubles that this could generate for the family. The mother became very frustrated, began to yell at him. The mother and the father experienced a lot of marital tension. The father experienced hallucinations from being tortured in war, and his symptoms were aggravating with time. He took antipsychotic medication but became highly paranoid and aggressive. There was a very severe incidence of domestic violence where the father locked the mother in the bedroom, attacked her, and tried to strangle her. Thank God the brother visited the home. I think he was called by one of the children when the mother was screaming, and thank God he was living close by, so the brother, who was actually a fighter, a boxer, very strong man, broke the door and separated the woman and called the ambulance because she was really close to dying. She was really very close to dying. Unfortunately, the children saw this severe domestic violence, and that was very traumatizing to them, including the subject. The father was placed in a mental institution. The subject continued to steal obsessively and eventually entered the juvenile justice system. Physical abuse by older brothers continued, and the subject started showing symptoms of epilepsy. He was prescribed medication, and then he was placed in a mental health institution for 6 months to rehabilitate. Upon release, he became addicted to prescription drugs and abused them profusely. I don't have the details of the medications he was using. Really, the medications is not, like I said at the beginning of my presentation, I'm not an expert. I'm basically a social worker, so I don't have much experience working in mental health. So, but I was more interested in the social history and the qualitative, part of his situation, and some intervention that I could produce that hopefully will result in positive life changes. The brother invited me to help, with the family situation. He was a friend of mine. And continue with the social history. The subject managed to manipulate various health providers and physicians to give him large amounts of medications. Serious behavioral symptoms observed on a frequent basis, including manic depression, aggression, prolonged absence from home, and disorientation. He would be lost in the neighborhood. One time he ended up being in Sydney, even though the family was living in Melbourne, and then he was lost, and it took them a while until they found him. By his early 20s, the subject showed full-blown symptoms of schizophrenia, delusions, hallucinations, disorganized thinking, speech, abnormal motor behavior, for example, sudden agitation, neglect of personal hygiene, etc. Currently, he's obsessed with bingo numbers. Constantly, he's asking someone to pick from a range of numbers for bingo. That was one of the behaviors that I constantly observed with him on a daily basis. I basically spent with the family, I would say it was about 4 weeks. I was staying in the home of the brother, and the subject was living in the back in an apartment that he had for himself. The reason why they didn't keep him in the same home is because he was abusing the phone lines at some point, and he started making harassing calls to people in the community. The subject can become currently aggressive if he is not given medication. Medication is given by a nurse, by a nurse there that goes to the house on a monthly basis to provide the injection. But this is problematic because sometimes when the nurse shows up, the subject is not there, and sometimes they're not persistent in finding him. So the subject might be without medication for a prolonged time. And that becomes a concern because he becomes aggressive, highly paranoid. I'm going to talk now a little bit about the subject's strengths as I observed them through my interactions with him. He appeared quite friendly and sociable. He had some friends, primarily homeless people, that he tried to help, to provide food for. He smiled a lot. He had a very positive energy, I should say. He had a very rich vocabulary in Greek words, and something that was really stunning to me, and I don't know, how can this be explained, is that his fluency in Greek was higher than the fluency of the caretaker brother, who was 2 years older, was born in Greece, and so I couldn't figure that out. The brother told me that he listened to a lot of radio when he was being raised by the mother, so that's how he explained it. I think also the brother had more of a need to assimilate to the Australian society than the subject. That was my That's my hypothesis or assumption. Okay, the brother believes to God, occasionally goes to church. He has dealt well with the loss of his mother, which happened recently, and also the loss of several of his brothers. And he does show resiliency over loss. I'm not sure if it's because he doesn't understand the loss. I mean, he seems to be understanding the loss, but he's definitely very resilient about it. He's very positive in his energy. I should say here also, when I'm speaking about the loss of brothers, that several of them died because of drug addictions. He cherishes the loving moments with both his parents when he was a child. He says that they both showed him a great deal of love when he was a young child. he was compliant with the researcher's suggestion to take showers, shave, and change into clean clothes, even though he did not comply with such a request by his brother. Of course, I had an informed consent to work to do this case study. I was invited by the brother, and we explained it to the subject. And he agreed for me to have discussions with him and interactions to do some observations about him. Okay, as far as the intervention focus and strategies, the intervention with the subject, contact with the client was on and off for about a month. I spent with him at least an hour and a half every day. It was definitely strength-based, my approach in dealing with him. I tried to talk a lot about the strengths that I've seen in him, tried to help him to feel appreciated and respected. And he really enjoyed that. He really cherished that. So whatever positive I saw about him, maybe it was his smile, maybe it was something that he said, maybe a Greek word that he shared with me. I was rewarding him for that, and that helped to develop some relationship there, to build some rapport, and help him to open up to me as well. I also tried to celebrate the strengths that I saw, and mostly the meetings were taking place in the living room and in the kitchen. The researcher also occasionally prepared meals and ate with the subject, the researcher being me. So sometimes I will cook for him something easy, and he did like that. He did like me taking care of him, which also helped to build the relationship. Occasionally, I took a walk with a client in the neighborhood with the dogs. They had some dogs, and we took a short walk, which again helped to strengthen our relationship. Okay, now as far as interventions with the subject's brother, I noted that the brother often was losing his temper. He was becoming very angry with the subject. So this led the subject to be distrusting and disobeying the brother. So I worked with the brother on more communication, on more productive communication strategies. Basically, I used the psychoeducational intervention approach, where I discussed with the brother, and I try to bring some awareness to the client. What is it about your behavior that is triggering that anger from the subject? What is it about your behavior that is making your brother distrustful of you? What is it about what you are doing that doesn't help your brother to listen to you? So I try to increase his self-awareness, and that eventually I was able to get that across to him, but it took some time. Initially he showed a lot of denial in terms of understanding how his behavior impacted the subject's behavior, but eventually, progressively, he did make good improvement. I also tried to role model effective ways of interacting with the subject. So I asked the brother to stay and watch me in the way that I was speaking to the subject, in the way that I was interacting with him. I wanted him to see the subject's reaction to me, to see how a more positive behavior would bring about a more positive reaction. Following this, there was debriefing with the brother and behavior analysis to help the brother understand how to help the subject build the trust. And the brother was asked by the researcher to role model positive behaviors and productive communication techniques with his brother. For example, better listening, complimenting good behavior, asking him in a nicer way to take a shower, shave, change clothes, or tie up his room. And the researcher I provided feedback after I observed him. The results were definitely not immediate. It took the subject 3 to 4 months to start seeing his brother in a more positive light. And the way that I stayed in contact, we did a lot of electronic communication through email and sometimes Skype, where I was being informed about the progress by the caring brother, the caretaker. At the one-year follow-up, even though the brother reported that communication was much better, he admitted that on occasion he continued to lose his cool, his temper. The brother stated that the subject took showers, shaved and changed clothes, and tied up his room more frequently. Sometimes he would resist, but there was definitely some change, some positive change there. The subject also improved on bringing less people from the street to overnight with him, which frustrated the brother due to the safety risks involved with such arrangements. The subject also improved on taking his medication more consistently. In other words, the subject was more consistent in being there when the nurse was coming to give the injection. The findings of this case study in the context of previous research, Hassan et al. In 2015, this year, they did a psychoeducational intervention with people diagnosed with schizophrenia and their caregivers. It was a randomized controlled trial study. The relapse rate with hospitalization was reduced significantly at both follow-up times in the intervention group. Significant improvement in the primary caregiver's knowledge score at post-treatment and 3-month follow-up was also observed. The primary caregiver's burden of care was significantly reduced in the intervention group, and their quality of life improved. The conclusions were that the psychoeducational intervention was very promising with both schizophrenics as well as their caregivers. The strength-based approach to case management and treatment, there was a review done by Rab and Gosha in 2008. I hope I pronounced their names right. And they reviewed a bunch of evidence for the last 25 years generated at the University of Kansas School of Social Welfare. And their review demonstrates that strength-based interventions are much more effective in case management of schizophrenia than the traditional problem or pathology-based approaches. Medication overdose, Moore and Shukla in 1997, they did a report on a case of a woman with schizophrenia who overdosed on risperidone and became suicidal. The subject was admitted to the emergency room. She was awake, alert, and oriented to time, place, and person, but tearful and depressed. When treatment with risperidone resumed 48 hours later, her akathisia, the difficulty with sitting still, depression, and hallucinations improved. A 29-year-old male who also overdosed on this medication also became suicidal. As far as child abuse as a contributing factor to the onset of schizophrenia-related symptoms, McCarthy, Jones et al. In 2014, they found that childhood parental emotional abuse impacts the FOXP2 gene involved in the development of speech and language, and therefore contributes to the development of auditory verbal hallucinations. This interaction was specific to auditory verbal hallucinations and did not predict the likelihood of nonverbal auditory hallucinations. Alemany et al. 2015, they examined the histories of 198 individuals in Spain and concluded that individuals experiencing child abuse were more likely to develop psychosis as adults. DeRose et al. In 2014, they confirmed the linkage between child maltreatment and psychosis using a much larger sample, which was 631 people, pretty large, I would say, in the United States. Child kleptomania and epilepsy as predictors for schizophrenia. Chen et al. In 2003, they warn us that kleptomaniac children may be misdiagnosed as having schizophrenia, when in fact they may suffer from other mental illnesses such as Asperger's syndrome. My review of the literature didn't find any other paper that was connecting kleptomania with schizophrenia. This was the only study that I came across, but I think that's something that would be interesting for further research to look into. Bob et al. In 2010, they found neurological evidence supporting the connection between epilepsy and paranoid schizophrenia. And again, I didn't find a whole lot. There is some studies on that. There is more studies on that than kleptomania, but not a whole lot about that connection. Okay, my conclusions based on this case study. Of course, there are limitations to my study, but they're obvious. You know, I only used one subject. It was self-report data. There are obvious limitations, but as far as some of the conclusions that we can derive, severe child physical abuse and medication overdose should be further explored by research as potential antecedents for schizophrenia. You know, there may be contributing factors to schizophrenia, as research also has shown, but I think it will be interesting to examine this also together, you know, the effects of physical abuse and medication overdose taken together, meaning, of course, the history of child physical abuse. Okay, individuals suffering from schizophrenia have numerous strengths that intervention can build upon to become more successful. Strength-based intervention can be very productive with schizophrenics. Caregivers often need specialized training to learn how to communicate with schizophrenics in more effective ways. And of course, there are families that are doing a great job with that, and I think that depends also on the educational level of the caregiver. The particular caregiver did not, he had a high school education, he didn't have university education, but I'm sure that plays into this. So definitely some caretakers are better than others, you know, doing that. Positive behavioral changes in schizophrenics are possible when caregiver attitudes and behaviors change for the better. Positive changes may not be immediate following intervention. Persistence in intervention may eventually bring about desired changes, at least partially. Change in caregiver attitude may require a focus on self-introspection and associated professional monitoring and feedback. And these were the references that I used for this presentation. And thank you very much for your attention and your time. And do you have any questions for me? Yes.
Your talk about the gentleman in the first case, I noticed that you mentioned about his not being there quite often when the nurse would come. I don't know about in Victoria, but in New South Wales we have what's known as community treatment orders that a magistrate makes, so that a patient becomes compliant, otherwise they end up being scheduled to an involuntary hospital. I mean, was that ever an issue, or was that something that was overlooked, or?
What I noticed is that there was some lapse time where, you know, he was scheduled to have his medication, let's say today. The nurse will show up. The subject will not be there. This was reported to me. It did occur also when I was there, that the nurse came and the subject was not there, and we ended up driving him, you know, to take his injection. But from what it was reported to me by the caretaker in the past, there were many times where the nurse would show up. The subject would not be in the house available. The nurse kind of gave up on him a little bit. He will show up like 2 weeks later, and I don't know why that is. I don't know if they have a big caseload, you know, and and they're very busy. I mean, he will try to make an attempt, let's say 2 weeks later. Sometimes the subject will not be even available then. So there was this lapse time, you know, where he was not taking his medication on time, and that had a bad impact on his behavior because he would become more aggressive. He wouldn't listen, paranoid, you know, that kind of thing. Yeah. Sure. And another thing that I observed, I think their focus there was more about the medication, giving the medication, but they didn't do a whole lot with the family. That was my observation, and it was a little disappointing to me that they didn't try to help the caretaker interact better with the brother and, you know, teach him listening skills and that kind of thing. because he was definitely, neglecting himself. His room was messy and dirty, and he wouldn't change clothes and shave. So those were very observable behaviors. I don't understand why they didn't try to do something more effective, and they just isolated their attention on medication. That was something that concerned me.
May I pose a question to you, sir?
Sure.
Up here.
Absolutely.
Actually, two questions. As you observed this boy, was he aware that his behavior was a problem? Was he in any way motivated to not have the problem?
I wouldn't say he was aware. I would, you could see that he knew that people were looking at him in a different light, in a different way, differently. There was something different about him. I think that he knew that, but I'm not sure if he understood that he was,
Okay.
suffering from an illness.
Okay. Now, my second question, when we speak of schizophrenia, we speak of a phobic element, of a, not a phobic, a psychotic element. What was the symptom that led you to conclude schizophrenia was a valid diagnosis?
Well, he had a formal diagnosis from the services there for a long time.
Okay.
So it wasn't. I didn't diagnose him. He was diagnosed. That's why he was getting his injection.
Did you personally observe any psychotic symptom?
Yeah, for example, the bingo thing, where, we'll converse and constantly he will ask me for a bingo number, give me a bingo number. Sometimes he will be listless, while he was sitting, and he would become a little nervous, and I was trying to maintain the interaction, but he would want to leave, Even though he did like me a lot, we really, there was a good
Bonded.
relationship. He seemed like he was trusting me a lot, and he shared a lot of personal information with me. Does that
Thank
answer
you.
your question? Yeah. Yes.
I had many patients like him in my work in the UK, as I work with people that they just left jails or prisons or probation services and all that stuff. And they had many problems of giving dual diagnosis, and they're confusing schizophrenia elements with personality disorders. And what you're describing here is like, to me, it flashed my mind that it's also personality disorder or borderline personality disorder with psychotic elements or something like that, which actually fit very well to what you said about abuse and schizophrenic elements or all that stuff. Have you thought about personality disorders at all when you were doing all your approach to it? Yeah, that's a fair question. I have another one later.
Yeah, and I have to be honest with you guys. I'm not an expert in schizophrenia by any means. I'm not an expert in mental health. I have done a lot of research in child abuse and various social issues and domestic violence. And I'm a social worker, so I'm more of the on those social issues. So my opinion wouldn't count too much because I'm not an expert in mental health as far as what his diagnosis is. But I definitely thought that some of the things that you see in the literature as being the standard symptoms, I didn't necessarily see with him. For example, I never saw him being depressed. He was very pleasant to talk to. He laughed, he smiled a lot. You could carry a conversation with him. Like I said earlier, I was really impressed with his, with the extent of his vocabulary, his Greek vocabulary. Some of the words I didn't even know how to open up a vocabulary, really. To know what he was. So I was really impressed. So I could see some intelligence there. But then, some of the things that he was doing, like the bingo, every 5 minutes he would ask me for a bingo number. Tell me a bingo number. Some of those things that are not, normal.
Thanks. And I have another question. You were talking about strength-based therapy and educational psychoeducation. Can you tell me a little bit more about this? The psychoeducation and the base.
Yeah. Basically, what we mean by strength-based, at least in social work, is you really try to find out what are the strengths of your client, and you try to build on those. When people are recognized for the strengths that they have, they are more likely to build a relationship with you. And in treatment, the therapeutic relationship is the core, right? It is the epicenter of whatever you do. You cannot really be effective in any kind of treatment if you don't build that relationship. So that's basically what the strength-based model is. It's about locating the person's strengths and building on those. How do I build from those? If they're a hard worker, if they have a hard work ethic, maybe you can find something that they can do that will release some of that energy. And I'm sure I have read articles where schizophrenics, for example, people suffering from schizophrenia, because we shouldn't be attaching those labels, that they have been very effective, they have been very functional, for example, working in restaurants so it's about, finding what kind of strengths does this person have. If they have a hard work ethic, maybe they can work, in a field that they can work, that kind of thing. And your second part of the question was about psychoeducational intervention. It's what I did with the brother was more about educating him, bringing self-awareness to him, introspection, and understanding the impact of his behavior on his brother. I think there is all kinds of different models out there about psychoeducation.
Yeah, I know that. I was a little bit confused because me as a psychologist, when we talk about psychoeducation, which is normally the first step of every actual therapy that we do, is that we're explaining all the psychological models that we use or how we use them for the patient to have awareness of what the steps are of the therapy and maybe their symptoms. So that's why I was a little bit confused. So that's okay. Thanks very much.
Sure. Thank you for the question.
I'm a family physician. I wanted to ask Professor Jager, I've got a couple of patients who are schizophrenics, and with them everything is, I feel like they're emotionless, monosyllables, yes and no answers. In your opinion and your experience, what would be the role of subliminal therapy? Would it help in this mental illness? Because when you send them to a psychiatrist, they just come back basically with a repeat prescription. Thank you.
I have been impressed, progressively impressed for many years in my awareness of the extent of mental capacity of humans. Such things as rapid healing in physical terms. Such things as interventions that have no explanations, phenomena that we can't explain. My first career was as an engineer. My thinking is still conditioned to think like an engineer in absolute, rigid, logical, progressive ways. And this method, the application of it is precisely that. As I listened to this case presentation, my goodness, I wish that boy were here. I would love to demonstrate the use of this method with this young man if he is motivated. But he has to have that sense, that self-awareness, and the desire to be different. Given those elements, I think the odds are very high that that young man could be turned around. Now, if any of you want to continue this discussion, stick around here with me. We'll just keep going after we conclude the formal session. I'll demonstrate the method. I'll demonstrate it by applying it in a real situation here. and answer further questions and so forth. I don't feel I have adequately answered your question. But that'll do it for the moment. Stick around and we'll discuss it further. Any other questions from my colleague here? Okay, shall we formally end? Then let's formally end. Uh-oh, we have one more question here. Okay, for you.
I didn't quite catch why did the patient was taking a lot of prescription drugs before schizophrenia kicks in. I didn't cut it. Why did
Yes.
he was getting drugs before
Yes,
that?
initially it was for his epilepsy,
Okay. Okay.
and then following that, he was diagnosed also with schizophrenia at a young age. So it was a combination of both medications. But brother said that he was extremely overdosing them. He learned the system. He learned how to manipulate the psychiatrist. So he knew exactly how to get the drugs, and he was getting them from different psychiatrists.
But he was diagnosed earlier as a schizophrenic from before he showed the full psychotic
Yeah.
elements, like elements, yeah.
Yeah, initially it was epilepsy, and then following that, yeah, it was psychotic.
But maybe the psychosis, maybe it was in the beginning, maybe was it from the drugs, maybe it was linked with the drugs that he was taking for epilepsy or something like that.
Yeah, personally, if you're asking me, my personal opinion, I'm not an expert on this, but that's my personal opinion. I think that medication overdose that he did, in addition to his child abuse, because those were very strong themes in his childhood.
Yes.
There were very strong themes. They were very recurrent. The medication overdose with the physical abuse that he experienced. And so I think that those two things, really contributed to his behavioral issues, and eventually to maybe the onset of schizophrenia.
That's very definite for us psychologists. We know that when there's abuse in childhood and any kind of this kind of very extreme issues that they have in childhood, they're connected with so many different things, personality disorders, maybe schizophrenia and all that stuff. So definitely, definitely starts. But the symptoms that you're describing, they're not clear towards schizophrenia. To us, it shows, to me, especially that I'm a specialist, I'm a forensic psychologist, and I'm dealing with personality disorders so much, and that's why they have so much differences in dual diagnosis and wrong. They see a child that has delinquent behavior, extreme behavior, manipulation. You use a very good word. When you hear the word manipulation in extreme form, we see that there's some kind of personality disorder there. So that's why I was a little bit like, what is the psychotic thing, an element of schizophrenia? And I was having more behavioral issues and problems presented. But yeah, that's why we're confused with how the drugs taking place and how we use what reason.
No, because as I know, the epilepsy and the schizophrenia are quite opposite. They don't go. They're opposite. I don't remember now because, but with the dopamine, the one has low dopamine, and the other is so the drugs that you take for epilepsy. There is a very high risk of if the amount is high, that the patient gets has psychotic symptoms. So I don't know if that happened in the beginning, and then maybe he was maybe they didn't take care of that symptoms to drop them, or maybe drop the doses of the drug, and then it went into a full-blown schizophrenia. I don't know, but I've heard about cases that of epileptic children, not around 15 or 16, that with the medication sometimes they were seeing things. So So, you know what I mean.
The brother
So I
did-
also agree that maybe there was some kind of a personality issue.
The brother did share with me that at some point he had, hallucinations and things like that. But that's very hard to confirm, with him.
If I may contribute one more remark relative to this case. As I heard the case presented, I was forming a mental image, concept, understanding of this young man. My conclusion was, based on the evidence at hand, I would seriously question the accuracy of the schizophrenic diagnosis. Now, I don't believe in true schizophrenic cases, treatment by this method I call subliminal therapy is apt to be successful. I don't know that it isn't. I've never had the opportunity to explore that. But in the case I was hearing, it was more of a behavioral problem. There are many things we do that are irrational, don't make sense. Simple example are those who smoke. I mean, why would any intelligent person damage their own body by this behavior? It's not a rational thing, but we don't normally consider that population to be psychotic. I envisioned this young man as being the result of constant, severe, emotional abuse. There are case reports, fortunately not many in civilized countries, but they exist there too, reports of a human being degraded, being injured to the extent that they begin to function like the more basal animals. We can be conditioned to be anything. It's all about conditioning. We can be conditioned to, any of us could have been conditioned to be a terrorist. It's all about conditioning. So treatment, successful treatment, involves reconditioning. Okay, let's formally end this session at this point. If you wish, stay with me. We'll talk further. Thanks for being here.
Thank you.